Hi everyone, today we'll be discussing CT imaging features of acute mesenteric ischemia. So first coming to bowel lumen. If you are suspecting a patient with mesenteric ischemia, here the bowel lumen will be dilated and fluid filled. Why it will be fluid filled? It's due to inability of the large bowel to reabsorb the water. When there is a decrease in blood flow leading to ischemia, in such cases there will be aperistalsis. When the total cutoff of the blood flow leading to infarction of the tissue, there will be loss of contractility. So when a patient comes like this, misinterpret as non-specific ileus and you have to look for mesenteric vessels. Then coming to bowel wall thickening, they present as target or halo sign. They will be having a circumferential edematous bowel wall. It's a non-specific finding because it can be seen in many conditions. So one of the conditions is venous ischemia. Here when you see, this is the lumen, this is the mucosa, this is the submucosa. Here we have outer muscularis propria and serosa. So when you give contrast, this mucosa gets enhanced and outer muscularis propria and serosa gets enhanced, giving a target or halo sign. And this part is edematous, submucosa. When there is fluid within it, it will be hypoattenuating. When there is hemorrhage, it will be hyperattenuating. In venous ischemia, it's also seen in strangulating obstruction, non-obstructive mesenteric ischemia, arterial occlusion with reperfusion. In these conditions, we see this target or halo sign with circumferential edematous bowel wall thickening. Here you can see, this is pre-contrast, this is post-contrast. Bowel wall thickening more than 3 mm, this is the lumen. Now once you give contrast, there is mucosal enhancement, there is submucosal edema, enhancing serosa or outer muscularis propria. This is normal bowel, pre-contrast, normally it will be homogeneously hypoattenuating. Post-contrast, there will be normal homogeneous enhancement. Coming to bowel wall thinning, where you see bowel wall thinning? In arterial occlusion you see bowel wall thinning. More, it is like paper thin appearance. Why it will be like paper thin appearance? It is secondary to loss of blood volume of the intramucosal arterial capillaries, intramucosal. So this is thinning. So intramucosal arterial capillaries, there is loss of blood volume leading to thinning. Enhancement will be normal. Now coming to bowel wall hyperattenuation or non-enhanced CT or unenhanced CT. Normal bowel will be homogeneously hypoattenuating. Thickened bowel will be hypoattenuating caused by edema. Now we are dealing with non-contrast CT, spontaneous bowel wall hyperattenuation. In the submucosa, if there is any hemorrhage, or non-contrast CT, we see hyperattenuation. So what happened in arterial acute mesenteric ischemia? Blood extravasation to the damaged vessel due to reperfusion. This is, in these conditions, there will be submucosal or transmural hemorrhage. One more cause is increased wall pressure caused by vascular occlusion. In these two conditions, there will be spontaneous bowel wall hyperattenuation. Non-contrast CT is very important. They both resemble same. After the contrast, there will be enhancement. Pre-contrast, there will be hyperattenuation. Two causes you have to remember: reperfusion of the arterial MI and increased wall. So coming to abnormal bowel wall enhancement, there will be decreased or absent enhancement or increased enhancement. Decreased or absent enhancement in conditions of where there is decreased blood flow, blood input. So then compare it with the normal adjacent bowel loop or enhanced images. Bowel wall hyperenhancement, increased enhancement, where it occurs in hypovolemic shock. Example, non-obstructive mesenteric ischemia, what happens? There will be spasmodic vasoconstriction and slow perfusion. This leads to prolonged bowel wall enhancement. This is shock bowel. Target sign, as you know, there will be enhancement of the mucosa and outer serosa with submucosa, edematous submucosa central. It's seen in venous ischemia, non-obstructive mesenteric ischemia, arterial occlusion with So this is decreased or absent enhancement. Paradoxical hyperenhancement. Pneumatosis intestinalis and portal venous gas. This is pre-contrast, this is post-contrast. You can see air pockets within the wall. This is called as pneumatosis intestinalis. This is suspicious for ischemia. Only air pockets within the wall, it can be associated with multiple benign causes. It does not necessarily indicate necrosis. Only this finding, there are studies which show the bowel is viable in many studies. So along with this, in the right clinical scenario, infarction is more likely when the pneumatosis is associated with portomesenteric venous gas. So how this gas enters the portal venous system? So first there will be a gas within the bowel wall. It travel via the mesenteric veins, then into superior mesenteric, inferior mesenteric with portal vein and liver. So pneumatosis intestinalis with portomesenteric venous gas in the right clinical scenario, infarction is more likely. Next finding is fat standing and ascites. This is mainly due to elevated mesenteric venous pressure or due to superinfection of the ischemic bowel. Leads to transportation of fluid in the mesentery and peritoneal cavity, leading to mesenteric fat standing and ascites. The most important and specific imaging features of occlusive acute mesenteric ischemia is that of involved segments of bowel corresponding to vascular distribution. Suppose SMA is involved, the parts which are supplied with SMA are only involved and remaining parts are all they are supplied with other vessels, so they will not be involved. So involved segments of the bowel corresponding to vascular distribution, that's very important. Abrupt interface between the normal and abnormal affected bowel may be seen. On occasion, distribution of the disease lead to diagnosis. By seeing this, we can know the diagnosis. At the same time, see the solid abdominal viscera, as other solid or organs are also supplied. For example, there will be peripheral wedge-shaped areas of hypoenhancement in infarcts like liver, spleen, kidneys. In embolic arterial phenomena and non-obstructive mesenteric ischemia, there will be hyperenhancement of the adrenal glands and kidneys. In CT, hypoperfusion complex and non-obstructive mesenteric ischemia. So look at the solid organs, look at the adrenal glands and kidneys where there is hyperenhancement in CT hypoperfusion complex and normal. Thank you.